Thank you for having us here at the Anterior Hip Foundation. This is great that we've broken up the meeting and can focus in on some of the stuff that people really want, those pearls from the beginning. So, as mentioned, I'm from Canada. I snuck over the border. I was allowed to come in and talk to you today about the anterior approach. And I think for a lot of us, when we're changing our surgical approach, it involves a lot of sort of preparation and planning ahead of time. And I think you have to really consider that. If you're coming, I came from posterior, depending what surgical approach you're coming from, you really have to take this as a serious undertaking in terms of learning, then in preparation as you transition your practice. So I think you really have to think about the planning of this. In terms of preoperative planning, I think it's all safe to say it can have a steep learning curve, but I think courses like this and cadaver labs and opportunities to see other people can really help shorten that. I think if you continue to plan, you're going to have better learning of the exposures. You're going to be much more efficient in how you do things. And I think overall it'll be safe. I mean, I look back 10 years ago when I first started, and there's definitely a lack of mentorship or a lack of direct help, and then how I suffered, and now how we were able to teach fellows and residents. And I think safety is a lot better now. I think the planning of this as you transition your practice is important. And if you really don't plan what you're doing ahead of time, you can set yourself up for failure. In terms of preoperative imaging and planning, we've always looked at the AP pelvis as sort of the determinant of how we're going to size our implants, and obviously everyone can do this regardless of surgical approach, with the goals of restoration of leg length, offset, center of rotation, and your implant positioning. So for us, definitely gold standard would be an AP pelvis. At our center, we also use a 3-foot standing x-ray. I don't think this is mandatory, but I think for a lot of patients, it can give you a good idea of where that leg length discrepancy is coming from. Is it truly coming from the hip? Is it coming from a varus knee? Is there already an implant in there? What is the pelvic tilt like on a 3-foot standing? Where's that lower lumbar spine? So while not mandatory and more useful, some people would say, for a total knee replacement, at our center we do use it for hip replacement. I think that truly gives you what a leg length will look like. And so if you're going to plan to be meticulous about leg lengths and how you measure leg lengths is with a 3-foot standing x-ray, I think it makes sense to have that ahead of time so you can plan. In terms of templating, I think the key thing, regardless of, everyone has templating software now, is you want to create a level plane. So whatever you use to create that level plane to assess your x-ray to determine your leg length and offset. So you can use inferior pubis, your interteardrop line. Sometimes I like to go up and just take that line, and just to make sure that it's actually a level plane, I'll take it up to the SI joints and just above and make sure that line's going straight across. Once I'm happy with that, then you can go ahead and template the rest of your hip and see what you're trying to restore. You're trying to determine leg lengths here. So leg lengths you can do from tip of the lesser trochanters, the outermost aspect of the lesser trochanters, to even the greater trochanters. I take a few different measurements to make sure my leg lengths are consistent. And then from there, you're putting in your stem. And then with a fit and fill, with a lot of these collared stems, some people are talking about a bit of varus. I'm still trying to primarily fill my canal with, in this case, a collared stem. So I think everyone can template. I think templating is ahead of time. I think with a lot of the digital adjuncts we have as we move forward, and as you use fluoroscopy and how you can integrate those into your practice, I think it's important to have a good surgical plan ahead of time. The last thing actually I'll say about that is, in terms of other adjuncts that I've learned, include the tip of the greater trochanter to the shoulder of your implant, and that distance intraoperatively is a good gauge of where your implant is sitting. As well as just measuring your neck cut when you've resected the femoral neck and comparing those ahead of time. Those can give you good guides of how you're doing. As was mentioned in the previous talk, I think if you are preparing to transition your practice and you're looking at a bunch of x-rays and who's a good candidate for anterior total hip, I think you have to remember that not everyone is the same. So the patient on the right, that is a dream patient, their pelvis is tall compared to the pelvis, which is quite wide on the other side. When that pelvis is tall, you have a huge working window, okay? And that working window is great because you can put your instruments in. This is going to be easy to access the femoral neck. Comparatively, on the other side here, you have an overhanging pelvic brim and a short femoral neck. Maybe not an ideal patient if you're first starting off. So if you're planning, I would not pick this patient off the bat. In terms of that cup again on the left, pretty straightforward. Comparatively here on the right, there's a lot of osteophytes. It's circumferentially held in. It's going to be a very tight hip. You're going to have to remove some osteophytes potentially before you can dislocate that hip easily. So I think you have to keep in mind when you're doing some of these cases is who you're picking. And finally is bone quality. While we all like to start on thinner elderly patients, particularly women, because their tissues are more supple, you have to keep in mind that that comes at the risk of their bone quality. And here, the guy on the left there, good quality bone, less chance of periprosthetic fracture. Patient over here, this is a patient I would choose to cement just given their bone quality. So if you haven't cemented before during the anterior approach, this might not be the ideal case to start if you're planning. In terms of table setup, at our center, we use the OSI HANA table and patient supine. So, I'm not going to go through exactly how to do this, but the nice thing about the HANA table, and I think most people in at least US-based practices, the majority are using HANA or a traction table compared to a lot of our European or international colleagues, which are not. It allows you to do basically hold the leg, hyperextension of the leg, control the leg in terms of rotation, and has a femoral elevator as well. So this is the table. I know they have a booth. I'm not going to run the whole video here to show you all the new toys that they have, and in fact, a new table, but I think this is the workhorse at our center for anterior hip, and I think across North America. And if you're not familiar with it, I would definitely familiarize yourself with it and all the adjuncts that it comes with. In terms of positioning, we've gone through several iterations in terms of how you want to put that patient on. You want them to be supine, obviously. Arms out. We used to fold one arm over to have more access to the surgical side, but that sort of rotates the body, and you lose a bit of your supine plane. So now for standardization, everyone's arms are out and held down. You want to make sure you use that safety belt. This is a narrow bed comparatively to other beds that you're used to. You don't want that patient falling over. You want to pad that perineal post. Before you start, and once you set up your patient in terms of planning here, you want to make sure that elevator has enough excursion. That elevator post that you're going to use to elevate your femur, that can move in and out. So depending on the width of the patient, you can accommodate this by moving that post in and out. And you want to check your pedal. That pedal is sensitive. If you run it over that cable, you can break it, it won't work. So you have to make sure everything is plugged in and working, and test all those things before every case. In terms of table prep here, you can see that we tape over the spars. You don't want blood or prep fluid getting in on that, and it'll degrade your actual table over time. I check the pedal, as you can see here, ahead of time just to make sure everything's working. And this is our basic setup. I've taped the skin out of the way, and I'd recommend you do this for every patient, big or small. Sometimes even small little ladies, if you don't tape their skin, when you're trying to close that skin, it sort of folds on itself, so you want to have a little bit of tension on that wound to be able to close it. And I think that makes it a lot easier. In terms of setup, in terms of feet, so at our center, we wrap the feet individually before putting them into the HANA table boots. There's a lot of different options for this. You can use a Coban. If you're really worried if they're small feet, and that's a good trick to keep the feet in the boot so they don't slip out. The last thing you want is halfway through your case, one of these feet coming out of the boots. And that happens when nurses or surgical assistants aren't usually prepared of how to keep the feet in there. We use a flannel, which is a lower cost option than a Coban, but I would recommend you do this for every case and then check it. That's an example ahead of time. And in terms of efficiencies, we often will do this in the block room, wrap the feet, put the boots on before the patients even come into the room so they're ready to go for surgery. In terms of pre-drape, obviously, everyone knows how to scrub a hip. I'm sure everyone goes home with a chlorhexidine brush they do the night before. Here they've had their final prep. We use sterile towels to drape out the genitalia and create our working window here. Make your landmarks. I think it's important that you don't drape yourself out. If you are doing an extensile approach, as was shown in the earlier talk, you want to have access to that iliac crest. If you want to take down the TFL, you can go down safely. You want to make sure you can come down the femur if you need to, or go subvastus if you have to really extend that incision. So you want to give yourself a lot of room. So I think landmarking ahead of time and making sure you can see those landmarks, putting some cross hatches to reapproximate your skin is important. Just highlighting there's an old previous bikini incision on that side. And then whether you do a longitudinal bikini incision, I think that's more minutia, and people will talk about it, but I prefer to use an eye band here just to take everything down. Some other people will use a clear drape, but I think the key thing is you want to seal off that entire hip area which you're going to be working. Next, so as mentioned, we use a combination of sterile towels. You can use U-drapes. A lot of my colleagues do use U-drapes. And our hip pack sterile towels just come in a little easier. I try to minimize the amount of drapes and wastage that we're going to have. After we've done that, you want to make sure that you landmark. As I mentioned, the ASIS is important. Make sure you can palpate that for every single case, which allows for extension. So as I mentioned, we use an I-band, or it's an iodine-based, basically, clear sheet that goes on top and sticks everything down. Then what you do on top of that is up to you. Again, you can use separate sheets here. I prefer to use a clear drape, which we use traditionally for hip trauma, or a DHS or a femoral nailing. You can use two separate, absorbent U-drapes. I prefer this because I can actually see the feet. So if I'm telling my nurse to dial in rotation, or my colleague, I can see where the foot is. I can manipulate the leg. I think if everything's covered up, when you start, you're at the mercy of whoever's working your table or whoever's there. So I like to have control and be able to see and visualize what I'm doing. And it's actually a very simple draping technique once you put those towels and the clear drape on top. So again, you can pick whatever you want. That's sort of the final product there. In terms of next, we obviously want to throw off your cautery section, make those go from the top and not the bottom, because the bottom, your legs are going to be going up and down and can potentially get contaminated. I seal those off with an extra top drape, which is really just to protect my anesthesia at the top. Final other little pearls or takeaways from this, I'd say, in terms of the draping is the elevator bar that you're going to use to attach your hook to bring up that femur. I like placing that on ahead of time. We used to do it once you started to do the femur, so halfway through the case. Now I do it ahead of time. We use a sponge underneath it, so the hand on the table has an extra extension lift for obese people if you want some extra excursion. If you put on a sponge basically ahead of time and then put on that extensor towel, it gives you a little bit of an automatic lift because it doesn't go down all the way, so it's an interference fit. So it's a nice little trick to make every case a little bit easier to get more excursion. And I mean, importantly, I like it because it holds my cautery and my suction during my case. So the advantage of this clear drape here is that all the blood that's coming out of here will be caught in here and keep your floor relatively clean. So remember, when you're prepping and draping here, layers are your friend. They're good. Obese patients, I think you need to have wider supports on that bed, and you're going to use tape. Tape is your friend to move the pannus out of the way to be able to access that hip. Make sure, once you're done all the prepping and draping, if you're using C-arm, you can bring in your C-arm safely and it doesn't hit anything. Don't rush the draping. It's a bit different than what you used to be used to in the lateral and posterior approach. And I think it's important to be consistent with your surgical team if you're trying to establish a new routine. So again, make it standard. And the positioning really determines your success, basically. And then make sure when you are transitioning your practice that you plan with those templates ahead of time so you can reproduce what you're trying to do. Thank you very much.